Now, Dr. Tripodi, sorry.
Yes.
We'll start with one question. When is the maximum risk of a thromboembolism in the stages of COVID-19?
I think that the risk is elevated during the host-inflammatory response, because there you start having the inflammatory response, which is quite high, with the I would say circulation of cytokines in the plasma, which can be responsible for the arrangement of both pro and anticoagulants and also fibrinolysis. So I think that's at that time point, the risk is relatively high.
Okay. And then maybe if Dr. Ortel is around, we can alternate questions till Prof. Bhivandi comes back. Is Dr. Ortel around? Or?
Yes.
Maybe we can alternate the questions. So why the DOACs failed to be the winner in the valves, while consistently they were the winner in many other indications? Is there a different pathophysiology there with the valves than we don't see it in others conditions?
Most likely that is going to be the cause. Very similarly with triple positive antiphospholipid syndrome, that there's probably something different about the pathophysiology. With the direct oral anticoagulants, you are only getting a single one of the prothrombotic enzymes actually targeted. And whereas with warfarin, you are lowering actually 4 different vitamin K proteins. The interesting concept would be whether or not we ever get to the point where we actually consider combining different DOACs. For example, could you combine a low-dose anti-10A and an antithrombin to see what kind of effect that you might get? But at this stage anyway, at least with the one drug that was investigated, it was not sufficient in that patient population.
Maybe a follow-up question on a related topic on the arterial thrombosis. You've shown that probably the rivaroxaban is better than aspirin, but does the addition of aspirin to the rivaroxaban compared to rivaroxaban alone add much of benefit?
Which patient population are you talking about?
When we're trying to prevent the arterial thrombosis, the study that you
arterial thrombosis. So the COMPASS study. The COMPASS study, it looked like, at least in for those patients with peripheral arterial disease, it was the combination of that low dose direct oral anticoagulant with the aspirin that seemed to be the most efficacious or effective at preventing outcomes. It was associated with an increased risk of bleeding, but it was the best option for preventing recurrent thromboembolic events, at least in patients with peripheral vascular disease and carotid arterial disease. Now, also keep in mind what they did for that study with rivaroxaban was what worked best wasn't just a low dose once a day dose, but it was actually low dose twice a day, which is very different than how rivaroxaban is otherwise prescribed. So it may end up being what you're trying to do is avoid those peaks and troughs by splitting the dosing out that way. And you may get similar benefits from a low-dose apixaban strategy as well.
Okay. Thank you. Now we go to Dr. Tripodi. Now, kind of a hypothetical question. So do you think hemophilia per se, without proper replacement, decreases the risk of thromboembolism in patients with COVID-19? Like, do our patients with hemophilia, if they get COVID-19, they are at a lower risk? And do you think now them getting replaced with prophylactic, like factor 8, let's say for hemophilia A, increases that risk?
Yeah, I do not have a personal experience on that, but I read something in the literature, and I think it was a report on a patient with hemophilia who was on prophylaxis with emicizumab, and actually he had COVID-19, but thrombotic problems were really not very important at the moment. So I think this is very important to collect the data from this patient. You may be right, probably in this patient, the risk of thrombosis could be a bit lower than the normal population, but it's very difficult to see it at the moment, so we have to collect information. But actually, it could be really, I would say, the situation like you mentioned, that given the fact that those patients have some procoagulant effect, even though they are on prophylaxis, for instance, with emicizumab, probably this may protect this patient from thrombosis. But you have to collect data because I'm not sure about this.
Thank you. Now, the question to Dr. Otel. I mean, two related questions, actually. Which is the DOAC of your choice? On kind of political thing.
Okay, so that's an interesting question. I think that for most patients, the DOAC I use most frequently is apixaban. However, for those participants, and I do have a number of people who say they can't seem to remember to take a pill twice a day, but they can do it once a day, I will use rivaroxaban. So I prefer rivaroxaban for the convenience of once-a-day dosing, but most patients I usually will treat with apixaban because I do like the twice-a-day dosing given the half-life of the drug.
Thank you. On the related question now, specifically, which of the DOACs has the lower risk of bleeding in cancer-associated thrombosis?
So none of the trials have actually done head-to-head comparisons between the different direct oral anticoagulants, and that's been a significant problem, I think, in trying to address these kinds of questions as far as between the DOACs, which would be safer or more efficacious. I think that the only thing that I would say is that the bleeding, the gastrointestinal bleeding complication rate seems to be a bit higher with dabigatran and with rivaroxaban than with apixaban and edoxaban. So there might be some difference in the type of bleeding across the different direct oral anticoagulants, but I don't think we have enough data to actually try to do a direct comparison between different ones.
And do you believe, compared to kind of standard of care, they do increase the risk of bleeding compared to, let's say, low molecular weight heparins?
In the cancer patient population?
In cancer.
I think there, if you just look at the aggregate, I would say no. I do think that we may find that there are certain types of cancers where there might be subtle differences as we continue to treat more patients this way. And there might be some differences, again, with dabigatran and rivaroxaban in certain patient subsets, such as those with gastrointestinal malignancy. There might be more of a problem with those particular ones in that particular setting.
In the burst of those meta-analyses that came after the first RCT, there was a signal, but it was not statistically significant, right?
There was a signal for bleeding, for major bleeding. But then when you looked at like clinically relevant non-major bleeding, that's where you started to see a significant difference. But with major bleeding, it was a trend, but it was not significant. That is correct.
Yeah. One could argue that, I mean, trials are powered to detect the primary outcome, not the bleeding outcomes and the safety. So are we confident that they do not increase the risk of bleeding?
Well, I think that for major bleeding, again, I think that when you look at the aggregate number of patients who have been treated over time, really we don't see an increased risk overall in that rate of bleeding, again, unless you start looking at subsets of certain cancer patients. But otherwise, we haven't seen that.
Thank you. Question to Dr. Tripodi. So, I mean, when you look at the multiple abnormalities in the coagulation that you see in COVID, which one would be, let's say, in centers where you have limited access to the advanced testing, which one that would be of your choice that we should do it, that would be independent when you put it in a multivariable analysis?
Difficult question to be answered, because I think that we should look at different parameters to have a clear picture of the situation. But if you have to make a choice, I think that for sure, the dimer, I think, would be the favorite assay, simply because it is very sensitive. But as I mentioned, it is very difficult to give it some, I would say, role in the management of patient, at least until data from trials, from prospective trials will come. At the moment, we know that it is a very, very sensitive parameter. So whenever the dimer is going to increase, for instance, if you look at the progression over time of the increasing levels of the dimer, you can define some good information, because it means that your patient is going to have an increased risk for thrombosis, even though the data, as I mentioned, are not prospective but are retrospective. But actually, I think that the dimer would be useful, particularly not the baseline of the dimer maybe, but also the progression in the abnormality of the dimer. Then I put some value also to the, if we wish to know something about the endothelial perturbation, which is very important in these patients. I think that you have at least to measure von Willebrand factor antigen, and even ADAMTS13, as I mentioned, could be useful. But actually, at the moment, we should collect the data and wait to see whether there are prospective studies which gives a real value in the management of these patients.
A related question on the significance of this ADAMTS13 level in predicting mortality. I mean, it's not easy to get ADAMTS13 for the classical indication. So is it really, does it really predict mortality if you test it, if you put the other clinical parameters in a model that could take out the significance of ADAMTS13 in predicting mortality?
Yes, I know. I think that's in the current studies, this has not been, I would say, accurately evaluated, because the sample size was relatively small, and therefore this analysis you are suggesting, multivariate analysis, has not been done actually. I believe that if the number of observation is relatively high, and there is a possibility just to look at your questions and see whether there is one or more factors which can be taken together. For instance, I can imagine a sort of scoring system which includes, for instance, some laboratory parameters and some clinical observation in your patient. And probably, I think that the score system is likely to be valuable in this context, but actually we have to devise first the score system, and then you have to validate the score system in a prospective population. And that, I think, is the crucial problem at the moment, because we only have at the moment retrospective information, which you can imagine in most cases are biased, and it's very difficult to give them some, I would say, value in monitoring patient, other than understanding the pathophysiology of hemostatic derangement in COVID-19.
So the two questions to you. In a lab with like basic hemostatic, not basic, but not very advanced research lab, how would you differentiate between quantitative and qualitative disorders of the fibrinogen, dysfibrogenemias or hypoaphyrogenemias?
Very good point. Actually, for this fibrinogenemia, you need to have the antigen level. And without the antigen level, you won't be able, I mean, you want to make sure with the Klaus that the activity is not there. But once you find out the activity is not there, you want to make sure that the level of antigen is not normal. Because then for the infusion of the concentrate is a is a problem, because if you make a wrong decision, you might bring arterial and venous thrombosis in a patient with dysfibrinogenemia, where the bleeding is much less.
Okay. Thank you. My other question is, when you do mutation analysis using like a more advanced NGS technology, I mean, you said when we do the PCR Sanger sequencing, we don't get the a positive mutation in a clearly a patient with the bleeding disorder. However, when you do NGS, the common problem is that you get many unknown variants. I mean, in bleeding disorders and in other disorders, that you cannot interpret well whether this is associated or related to the bleeding disorder.
That's a very good point. That's exactly what I wanted to say. Thanks for bringing that out. I think in Europe, this is a big issue because we don't have the big families with lots of generation, because the best thing would be to have more than 2-3 generations and more people suffering from the same type of clinical symptom. Even few families like that, or even one single family like that, can help you with the next gene to find out what are the genes that cause the disease. Now, if you're working on the single gene alterated disease, one very well organized family could be enough. But if you're working in a common disorder, when the penetrance of each single gene is not very high, then the trouble is there. Then one family is not enough. You need really huge numbers because the power of your study is much smaller and the role of each single gene is a little. So that's the reason why it makes more difficult. But for rare bleeding disorders, if there is a good phenotype and good phenotype lab and clinical evaluation, next gene would be helpful, I think. You need a good bioinformatician, of course, to clean up.
But you need more than one generation, right? Or...
Absolutely. Absolutely more than one generation.
So you cannot do it without siblings and parents?
You can make it in one single... I mean, you can do that, but your power is much less. You can do it more people on the same generation, but the power is really less, and you might end up with nothing.
Okay. Thank you very much.
I
guess we're coming towards the end of this session. Very interesting, very useful session. I would like to thank the speakers, Prof. Ortel, Prof. Tripodi, and Prof. Pivandi for their excellent talks. I would like to thank the organizers. And I also would like to thank the 4,612 attendees. Very good number. That is a reflection of the interest in benign hematology and in the session itself. So now we
like Ash. You're becoming the second Ash.
So we would like to invite the audience and other attendees to go to the exhibitor tour. It would be virtual. I promise you that you would see a lot of interesting and useful material. So please spend some time going there. And I guess because of the time issue, the break would be only 5 minutes. And with that, I would like to again thank the organizer for inviting me to moderate this session. Thank you very much.
Thank you very much. Ciao Armando. Bye Thomas.
Thank you. Bye-bye, Flora. Bye, Armando.
Bye.